Hi everyone, very good evening guys. I hope I am audible and visible, and welcome to the second part. I hope you all have gone through the first part where we discussed microbiology PYQs, and today we are doing pathology. I think I had already briefed you about this in the last session, but I'll take a minute and do that once again. I've not counted exactly, but there are 30 plus PYQs that I certainly have in this session, and the PDF of course that you will get will be after this session. But today, after this is done, I will be sending you both of course the PDF of this class, but also two unannotated PDFs of the previous and this micro and path session, so that if in later on you just want to go through the questions without the answers written in it, so you have that option as well. We are going to go again one question by the other, since most of them are previous year topics, means you've kind of mastered them, and if you haven't, then nothing to worry, you can do that right now as well. I have gone through all the comments and the doubts that were posted for microbiology, and I've replied to each one of you in the previous chat of the comments of the previous video, so you can look out for your answers there. If you have any questions about this session, you could put it in the comments here and I will get back to you over here as well. For those who are saying, ma'am, anxiety and all, I think the biggest anxiety that right now you guys are getting is because whenever you give a grand test, it is like another PTSD that you have to deal with at this point of time, because either you're not breaking that plateau or you're not getting the desired score, or with the new pattern and so much that is in general happening around. So it can be extremely overwhelming. So I decided not to mix this and today's session. Let's keep today's session purely PYQ and academic based. Tomorrow I'm meeting you at 6 p.m. for a very short 15-minute session of only talking about how to analyze and what should be done right now if you've reached that standstill position in your GT, or you're not able to score a good number in your GT as per your expectations. So I'll give you a 15-minute quick strategy tomorrow at 6 o'clock for that on YouTube itself, the same channel. But today what we'll do, we'll not dilute the topic and we'll focus only on previous year questions. I hope that sounds well, and we'll keep both these parts very segregated well enough. Okay, let's start. As I say, you need to read, you need to answer, and then we'll do one theory point also along with it, because PYQ copy paste is not coming anyway. Let's start with the first question. I've picked up more of lengthier PYQs to begin with. Here you have a 62-year-old man. There is fatigue and headache and pruritus after a warm shower. I think whenever in NEET PG you see these buzzwords, you know what I'm talking about. So there is itching after hot water bath. That is also known as aquagenic pruritus, and that hints me toward a very important disease, that is polycythemia, but I will read further. Examinations show splenomegaly, and if I've started thinking of polycythemia, the first thing I'll find out is hemoglobin. Hemoglobin is 19, very high definitely. The hematocrit, roughly normal hematocrit is going to be around a 45%. Here I can see it is 58%, so that is increased. Now next, coming to hemoglobin, if you're thinking of polycythemia vera, the hemoglobin should be more than 16.5, because we have a man over here, and in case it would have been a woman, I would have looked out for a hemoglobin more than 16, which is also fitting over here. Now I can see WBCs are elevated, platelets are also elevated. Now, why is this coming up? Because when we are dealing with polycythemia vera, obviously your first major criteria, as I said, the hemoglobin should be more than 16.5 or 16, or hematocrit should be more. But at the same time, the bone marrow will show you an increase in all cell lineages. This is very important. Pan-myeloses. That is why over here I see the WBCs and platelets are increased. Now further, all of this is happening because of which mutation was the question over here? JAK2 V617F mutation, and that is the answer. What characteristically has to be negative is BCR-ABL. You know what is BCR-ABL? So many PYQs, that is to do with CML, translocation 922, which is Philadelphia chromosome, and that has to be negative for it to be polycythemia. I think the major criteria are in front of you, but further you saw bone marrow, hypercellularity, all lineages are increased. This means it is pan-myeloses. Further, if I look back, they have said that there is activation of tyrosine kinase signaling pathway. And now if I ask you that what in turn JAK2 V617F mutation does, it activates the tyrosine kinase signaling pathway. And if I go back, if I'm saying all cell lineages are increasing, RBC, WBC, platelet, that is why the patient is having aquagenic pruritus, because when there there is an increase in the mast cells or the basophils, they will release histamine, and histamine will cause that pruritus whenever a warm water bath is taken. Everything is fitting perfectly well. Now if you ask me what are these two mutations, I am coming to them in a while because I have one or two more questions coming your way from the same topic, but I hope this was pretty simple. Now tell me, if the myeloid or the white blood cells increase, the clinical feature is aquagenic pruritus. When the platelet or megakaryocytic, whatever you want to say, that increases, clinically what is that going to result in? Again, a medicine point which they can ask you. Erythromelalgia. What is erythromelalgia? See, platelets, very tiny platelets, hardly 3-4 micron, extremely small. They are small in size, but now imagine thousands and lakhs of platelets blocking the capillaries of your fingers or your feet, your toes. Capillaries are very small. When those platelets will go and block the small capillaries, patient will have a lot of burning sensation. That burning in the hands and the feet, that is known as erythromelalgia. So these three buzzwords you have to look out for: aquagenic pruritus, erythromelalgia, and anything that is increase in hemoglobin. I think question 1 spent good amount of time, settled in the class as well. We move on to question 2. Here we have a 58-year-old man with multiple myeloma developing progressive edema. When I try to correlate these two things, multiple myeloma is today I'm not making you solve, that you tell me the answer. I'm going line by line. Let's go one by one. What all can I think of as a doctor in general, not just as a MCQ ratification. Okay, just let's think like a patient. I have a multiple myeloma case. That is a case of plasma cell cancer. And when they say progressive edema, I could think of one organ getting affected, that is kidney. I could think of another organ getting affected, maybe cardiac. Let's read further. And they say urine analysis, so I know they're talking about the kidney disorder over here. And heavy proteinuria, albumin coming out, fat also coming out, tells me which syndrome. I will start thinking of nephrotic syndrome. Okay, so now they say kidney biopsy shows amorphous. What is amorphous? No morphology. So this is not a cell. No cells are seen. Pink color eosinophilic deposits in the glomeruli and vessels, and they are Congo red positive. Now that is making sense, because what does I mean by Congo red amyloid? Amyloidosis clinically कैसे present करता है? In the kidney, when it affects, it causes nephrotic syndrome. And now obviously, because if it's Congo red, it will be apple green birefringence. They've asked you what is the deposited protein. Multiple myeloma, cancer of the plasma cells making more of immunoglobulins, especially the light chains. So that is what I think of. But tell me, is it to do with heavy chains? No, it is light chains. In fact, the amyloid is known as AL type of amyloid. Where do we see SAA protein? SAA means the amyloid will be AA type of amyloid, and that is seen with any chronic inflammation like chronic pancreatitis, chronic appendicitis, chronic vasculitis, any chronic inflammation, any cancers like Hodgkin's lymphoma, renal cell cancer, any cancer coming to your mind, and any fever, let's say Mediterranean fever, any of inflammations, cancers and fevers. What do? All of these are going to increase an interleukin. So everything I could not discuss as previous year question. Now I'm telling you points which have come as previous year questions. जब भी inflammation, cancer or fever happens, which interleukin predominantly increases? Interleukin 6, that has been a PYQ, and that goes and increases SAA. When that SAA increases is when the amyloid is formed, that is AA type of amyloid. Finally, coming to the last one, beta 2 microglobulin, that is associated with hemodialysis. Remember, 2 kidneys, 2 betas is how we had learnt it, because where do you see a beta type of amyloid? 1 beta, 1 brain, that is seen with Alzheimer's disease. So a very quick recap that you've done of amyloid. Now that you've done this, solve the one or two more questions will come, but एक चीज मुझे और बता दो. Congo red is giving you apple green birefringence. That is on which microscopy? Easy question. This is not what I'm asking you. That is on polarizing microscopy. My question is that if you are working in a lab and in that lab your microscope has a UV light, it doesn't have the usual light bulb. Your microscope is there, it has an ultraviolet light. Now which stain will you use for amyloid? Now you don't use Congo red, now you use thioflavin T, and that's also another previous year question. We learnt it as TUV. So thioflavin T stain is used when UV light is being used. I think all of you are right, getting perfectly right answers. When I feel you've gone grossly wrong, I will point it out. Right, but otherwise till then I think all of you are giving perfect answers, and I will not pinpoint each one of you, right? Moving on to the next one. This has been very similarly asked in very recent INI-CET and FMG exam. Something about this might just come up in NEET as always. 59-year-old smoker presents with weight loss and persistent cough. CT scan shows a central hilar mass. Anyway, this was going in favor of liver, in favor of lungs. And after lungs, when they mentioned hilar mass, I think with that and a smoker, I thought of lung cancer. And with smoking, the two lung cancers I think of is squamous cell and small cell. But guys, never be biased only on the basis of smoking history. So many people have come to me saying that, ma'am, there was a smoker history, but in the biopsy, it was written that glands are noticed. Glands tell me adenocarcinoma, and adenocarcinoma is not very commonly seen with smokers. But tell me, what will you rely on more? The patient's history of smoking or non-smoking is more gold standard, or biopsy is gold standard? So final diagnosis हमेशा biopsy पे बनाना, not just because patient was smoking or not. Here the biopsy shows you small blue cells. I think you started thinking of small cell cancer. Further, they say immunohistochemistry. Can you see in positive, synaptophysin, chromogranin, और क्या क्या हो सकता था? Because you started thinking of small cell lung cancer, and everything about it is written over here. The examiner might write it as oat cell lung cancer. That was the old name when the examiner did his or her MBBS, tab oat cell cancer hota tha. So that name can always come, and we call it the chota packet, but this is the bada dhamaka, and that came actually in the FMG exam also. So this means it's going to show everything very maximally. It's a maximalist kind of a tumor, matlab sabse aggressive for the patient. It is going to show you all weird sounding these markers that make no sense, like synaptophysin, chromogranin, bombicin, ye last INI-CET ka question, INSM, and then short forms like CD56, CD57 and NSC. Is there something that I need to know about these 7 markers? All these in, and these 3 short forms, what do they hint me towards? It is a neuroendocrine tumor. Now tell me guys, any neuroendocrine tumor is going to show me the same set of 7 markers. Tell me one neuroendocrine tumor in the adrenal gland, that is pheochromocytoma. It shows you the same in वाली same list आएगा. Tell me the neuroendocrine tumor in the lungs, same small cell. Tell me the neuroendocrine tumor in thyroid. Thyroid का तो हर बार you think of papillary carcinoma, that is orphan ani, that is different. Tell me the neuroendocrine thyroid cancer, medullary carcinoma thyroid. So that will also show me the same in wala story. Remember, every neuroendocrine tumor will show you the same concept. Now coming back, small cell में ये वाला कौन सा microscopy है? Blue blood vessel. Blue blood vessel is known as Azopardi effect. This is also done. पूछा क्या था question में? Now they are saying the tumor is most likely associated with the secretion of. It has maximum paraneoplastic syndromes. The most common one is SIADH, syndrome of inappropriate ADH, antidiuretic hormone secretion. So that is the most common. But FMG exam mein recently the question came on Lambert-Eaton syndrome. They gave you a patient who was unable to get up or could not climb. So some neuromuscular problem was mentioned with small cell cancer. You had to think of Lambert-Eaton syndrome. वो नहीं होगा, so they will give you a case of Cushing's disease. Either which way, max paraneoplastic syndromes are associated with small cell. Can you tell me that ये PTH related protein कौन release करता है? PTH, parathyroid hormone related. Ma'am, if parathyroid hormone like something is being released in my body, then if there is an increase in PTH-RP, automatically the calcium levels will increase. And hypercalcemia is seen with which cancer? With squamous cell carcinoma of the lungs, which you are done. Because smoking के साथ यही दोनों सोचा ना. But over here the biopsy, always remember, biopsy is gold standard for any cancer based on which small cell, and thus my final answer is ADH secretion. Okay, now you could have thought of ACTH with small cell, ho sakta hai. Single best answer, most common ADH. All settled. Moving on to the next question over here. This is very similar to what we've done right now, so let's just go in continuity. 70-year-old man with progressive heart failure. Echo is what they'll be doing, and that shows you thickened ventricular walls with a reduced ventricular compliance. So now you're trying to understand, why is the wall thick? Is it a case of hypertrophy? Is it some deposition happening? And they have mentioned that there is deposition of amyloid. So amyloid goes and deposits anywhere, and that area becomes thick. That's the concept. So if it goes in the heart, heart wall becomes thick, ventricular thickness increases. Imagine amyloid goes in the tongue, macroglossia will happen. Amyloid goes in any liver, spleen, तो hepatomegaly होगा, splenomegaly होगा. Basically, amyloid makes everything become big and thick and fat. That is what it is. Now they are saying क्या है amyloid? What is the mechanism? Is amyloid a virus? Of course not. Is it autoimmune or iron? Of course not. What is the definition of amyloid? Ma'am, definition has 3 words and all 3 are PYQs. Amyloid is always an extracellular misfolded protein. Repeat with me because question आता है amyloid deposits within the cardiac fibers or outside. So outside it is extracellular. Why is it always pink in color? Because it is protein. Protein will be pink in color. And why? What kind of a protein? Misfolded protein. So now if I go one question back and I show you the amyloid question here, did you see kidney biopsy mein there was amorphous eosinophilic deposit? Why is amyloid always looking pink eosinophilic? Because it's a protein, a misfolded protein. So 2 questions on the same concept are settled for us. Now obviously you can see that maybe ma'am we were not seeing exactly same PYQs when we were doing our QBank challenge over the past 3 days on any app that you were doing it on. But now my concept is that if I show the same copy pasted screenshot PYQs, then why have you joined this session? So I have changed the PYQs, and that is exactly what the examiner will also do. And that will, the best example is what I'm going to show you next. Maybe you've never seen this previous year question in the bank, but you are seeing it here. But the topic is something that I picked up from there. There's a 29-year-old man with rapidly enlarging painless cervical lymphadenopathy, and lymph node biopsy is mentioned. That tells me that lymph node biopsy, infection, cancer, lymphoma, that zone I'm going into. Further they say immunohistochemistry. So ye raha ek photo, ye raha immunohistochemistry. I think if you, any of the 2 also that you could identify, I think it was good enough. What was it in the first picture that you identified? The starry sky appearance. So as soon as I saw starry sky appearance, I'm like, oh, that's Burkitt's lymphoma. And Burkitt's will remind me of chromosome 8 and any even number. Okay, so if I look carefully, out of these, the only place where I see chromosome 8 and even number is MYC. Why 8 with any even number? It could be 8 and 22, 8 and 14, 8 and any chromosome even number, because chromosome 8 is associated with MYC gene. Now my question is, which MYC gene should I write here? C-MYC, L-MYC or N-MYC? Out of these, it is the C-MYC mutation, because mostly a childhood lymphoma hota hai. Burkitt's, remember that African child always that you get, but that is exactly what I changed. It does not necessarily have to be an African child always, it can be some other adult person also. Now I know the confusing part is over here, which we will try to settle. HNE photo, do you identify this as starry sky? Nahi, kuch samajh nahi aa raha, but that's okay. Should every picture in the exam make sense to you? No. I will try to find out whatever makes sense to me. That is what my agenda is, right? So ये मुझे नहीं समझ आ रहा, but by the way, yeah, this is starry sky. But let's skip it. What do I see over here? CD79A. What is the concept of immunohistochemistry? What should you be getting? Perfect. Brown color मिलना चाहिए. Brown color होगा तो मतलब positive. What is your take on CD79A? Very much brown, positive. BCL6 में maybe brown. I mean, in the exam I can't zoom in, but now when I zoom in, I do see something brown, so maybe it is positive again. As I said, everything does not have to make sense to you. Next, coming to CD20, maybe brown. CD10, maybe brown. Maybe you can see some brownish tinge. Chalo mando, you cannot see in the exam any brownish tinge, but can you definitely see for KI67 that it is certainly almost entirely brown? So आप correlate करो starry sky appearance with B cell marker coming positive with KI67 coming almost nearly 100% positive. What else other than Burkitt's will you think of? So as I said, yes, these are all positive. Burkitt's में सब positive होता है, but everything doesn't have to make sense to you. If I look at the other options now, what do you see over here? Translocation 14, 18. Remember, 2 teenagers, 14, 18, teenagers are best friends. Which is the best friendly lymphoma that we have? It is follicular lymphoma, which has the best prognosis, so we'll make a big smile in front of it. What do you see over here? ALK. This has been the last year FMG exam question also. ALK activation, which is translocation 25. ALK ke to naam mein hai, anaplastic lymphoma. That is the lymphoma it's associated with. And they asked you in the FMG exam that anaplastic lymphoma is which translocation? Translocation 25. तो एक और PYQ हो गया. What is this? Cyclin D1 is getting overexpressed. That is a case of mantle cell lymphoma. Where do you study cyclins? I'm going into general path, but I can go anywhere. It's a PYQ challenge. When I go for cyclins, what are they asking you? Cyclin kahan kaam aata hai? Cell cycle mein. I've got one question. All one-liners I have kept today towards last 10 questions are wo jaldi wale one-liners. Over there, I'll come to this. Cyclins are of 4 types. Cyclin D, E, A and B. That is cyclin D works first, then E, then A, then B. We had learnt it as Dhoni ek acha batsman. So cell cycle works because cyclin D, E, A, B work in that order. That cyclin D gets overexpressed in which lymphoma? In mantle cell lymphoma. So I think this is settled for us and a good revision of all of these. Ab jo bacha. So what I'll do, I will take a little bit of space over here, but I think I told you how to learn all of this. I told you that you will write 3 numbers like this in order. And what was it? The age at which you become an adult, 18 years. The age up till which you are a child, so somewhere up till 12, so let's say 11 years. And somewhere in between you take it as 14 years. And when 2 teenagers are best friends, this means 14, 18, best friends, friendly lymphoma. Translocation 14, 18, follicular lymphoma. Then 11 and 14 right now you did was mantle cell lymphoma. तो बचा क्या? I am left with the 2 margins. When they say translocation 11 and 18, the margins are coming into place. That is marginal zone lymphoma. Now you've done all of your translocations also. And if they ever ask you what is 8 with even number, that is Burkitt's lymphoma. Let's move on to the next question that we have over here. Similar to what we did right now, we are continuing from question 1. I've not put similar questions together because then it gives you a bias. I've split them this time. 57-year-old man with fatigue, splenomegaly and hepatomegaly. So up till now it seems like a very vague question. Organomegaly is there. CBC is showing you pancytopenia. This immediately takes me कि कुछ hemat का problem है and along with that organs are getting affected. So now I start thinking of hematology. Next I say bone marrow aspirate reveals a dry tap. When does bone marrow aspirate show you? Nothing. No material. When in the bone marrow, ma'am, there is a lot of fibrosis, you will put a needle, you will not be able to take out anything. So this is something to do with fibrosis. But now my question is, who is making? Can you tell me one general path ka PYQ? Which is the most fibrogenic cytokine? Options are TNF alpha, TGF alpha, TGF beta. Fibrosis is always by TGF beta. And now my most fibrogenic, बहुत fibrosis, that is how we had learnt it. Do you know who makes TGF beta? Because if TGF beta is formed, then only fibrosis must have occurred. That is made by the platelet precursors. What are the platelet precursors? Megakaryocytes. So do you know in the bone marrow, the megakaryocytes, they release TGF beta. That is why fibrosis occurs. And hence you will notice biopsy karne par we saw there was a change in the megakaryocytic morphology. That makes sense. Megakaryocyte mein problem tha, they started making TGF beta. That is why myelofibrosis occurred. And then they have further said that there is a special stain. Can you see these black fibers? This is the myelofibrosis that we are talking about and the answer over here. Now my question is, CML bhi aage jaake can cause myelofibrosis. Essential thrombocythemia can also cause myelofibrosis. Do you know even polycythemia vera can cause myelofibrosis? Fibrosis happening in the bone marrow is many reasons. Do you know even hairy cell leukemia can cause myelofibrosis? But my question over here is, if you were thinking of CML, could I make a diagnosis without doing Philadelphia? No. If you were thinking of all of these, polycythemia, ET, so JAK2 mutation, but ma'am, all of that was not mentioned. There was nothing else mentioned other than dry tap, megakaryocyte ka problem. So my single best answer with this situation will be myelofibrosis. I hope you've understood, because in your explanation of the Q bank, you will see that ये सब चीजों से fibrosis होता है, but then you should have supporting evidence to mark these as your answer. Okay. Moving on to the next question. I think this is from general path, easy, ultra easy question that you've seen in your PYQ bank. All of the following are true about neutrophil extracellular traps except. Is it seen in sepsis? Yes, it is. So what is sepsis? Severe bacterial infection. Some bacteria, parasite, fungus, something has come. Who comes to your rescue? Neutrophil comes to our rescue. क्या करता है neutrophil? Neutrophil is going to send all of its chromatin outside. All the nucleus chromatin is going to go outside, and then it will destroy all the bacteria, virus. So is it between the chromatin of the nucleus and the antibacterial enzymes? Yes. Is it a war between the bacteria and the neutrophil? Yes. Is it seen because of severe infection? Again, yes. What is it not? Is it mitochondrial DNA? No, mitochondria is not not being sent outside, it is the nuclear DNA. Nucleus bahar bhej rahe hain na, nucleus is being sent extracellularly. Now that brings me to the next year ka PYQ. Nuclear DNA going outside means that what antigens are going outside? Ma'am, nuclear antigens are going outside. Do you see your nuclear antigens? No. Your nucleus is always inside. You have never seen your nuclear antigens. Now your nuclear antigens have come outside. Don't you think you will start making anti-nuclear antibodies, and that could have a side effect of patient having SLE? That was the next year PYQ that came. What is the side effect that can happen? But now I'll ask you the next question. Whenever a bacteria comes into your body, कोई भी staph, strepto, pneumococcus, कोई भी bacteria आएगा, the first thing that you do is that nets? No. Whenever a bacteria comes into our body, our plan A is what? Plan A is phagocytosis. Phagocytosis क्या होता है? Eat the bacteria. Can I say that is intracellular mode of killing? Eat the bacteria, kill it inside the cell. If plan A fails and you're like, ma'am, phagocytosis was not working, now the patient has gone into severe infection. Now what is plan B? Plan B is kill it with nets, and nets will be killing it outside the cell, extracellular killing. And that's also another, these are all, I mean, how many PYQs could I discuss? So I thought we'll pick up one of every topic and then we'll extend on that. And these are the next year questions that have been put up on nets. Neutrophil, extracellular traps. I think this is okay. Yes, now can we move forward to the next one, which is seen over here. Every year something around this comes in a twisted language, but kuch to is pe touch upon hoga. There is a known case of hemorrhoids presented with fatigue after 6 months of blood loss. Do not think of anything, just clinically socho, piles, hemorrhoids, patient comes to you, blood loss. The first thing coming to my mind is that by now patient must have had iron deficiency anemia because of blood loss. So I did a hemoglobin, anemia is very evident, 9 grams. Now I start with these 3 values. First you will tell me the normal value. What is normal MCV? Normal is between 80 to 100 femtoliters. Here MCV is 60 femtoliters. I understand this is less than normal, this is a microcytic anemia. Microcytic aata hi I start thinking of that Sita Sheetal mnemonic. Anyway, I am thinking of iron deficiency, but let's read further. What is the normal MCH and MCHC? What do we say? We start from 27, we end at 37, and we put a break in between. 27 to 32 picograms is MCH, and start from here. 33 to 37 gram per deciliter is MCHC. I notice both of them are below their levels, matlab there is hypochromia, classic microcytic hypochromic anemia. But then this is what confuses me. I know you've got your answer, but I am giving it time because I want to tell you how to approach PYQs. As it is, to rata PYQ is not coming in the exam. There will be at some point a turn in the PYQ. You have to approach it accordingly. Even if you're like ultra confident now in the last 40 days while solving PYQs, give it the time that I have to revise my entire topic with it. At someone losing blood since 6 months and I am thinking of iron deficiency, RBC count should have gone down. But the RBC count in fact has gone up. Now that is something which is worrisome because that does not go well with iron deficiency. So now I decide I will do Menzer index. What is Menzer index? It is MCV divided by RBC. The MCV over here is 60, the RBC is 6 million. So Menzer index comes out to be 10, and I know if Menzer index is less than 13, I am thinking of thalassemia. This is not iron deficiency. Screening test of thalassemia Menzer index. So confirm kaise kare? What is the next investigation that you should be doing? I should be doing HbA2 levels, because if HbA2 levels are more than 3.5%, then it is going to be a case of thalassemia trait or thalassemia minor. Now I'll also tell you what we do practically. Practically we do both, because in this patient, because he was also losing blood since the past 6 months, I expect that दोनों चीज़ें हैं. ये तो he was asymptomatic maybe since so many years and he was not aware. Right now he has come to me because further the blood levels have gone down due to iron deficiency. Maybe it is a dual pathology, but that is, if a patient would have come to me, I would have actually done both, because I would want to do one test in one sitting. I would want to give the diagnosis, but now you have a single best answer situation here, and going by the Menzer index, theoretically single best answer is HbA2 level, but practically letting you know, you will in one setting when you've taken blood from someone, you will do iron studies also. right? And I know that everyone, as soon as you read this, सबसे पहले आपने यही सोचा, but then think logically over here, you would want to do a Menzer because this is anyway something that you are expecting. But currently what is undiagnosed, because thal minor usually goes asymptomatic, na? So this is after which patient might not even come to you. So this is something that you will have to do right now. Okay, all good. Can we move forward? Another general path question coming your way. What is the true statement regarding the telomerase theory of aging? This was all about reading and not getting confused because her statement similar sound kar raha hai. So let me pick up one statement. They say increasing of the telomere length is proportional to aging. Increasing of the length? No. I have always studied that there is a decrease in the telomere length and that is going to result in aging. So I think option C over here is making more sense. As the telomere is going to decrease, the person is going to age more. What is telomere? Let me make a chromosome over here. Telomere कहाँ होता है? नाम में है. Telomere is over here at the terminal end. Tell me the tell me the spelling or the nucleotide sequence of one telomere. It is TTA-G. This is one telomere. And again in the exam, telomere and telomerase same नहीं होता. Don't read it similar. यहाँ पर this is done. Okay, that as the telomere length will decrease, let's assume at birth, just a random number I'm giving. At birth you have 1000 telomeres. At birth. After that you will keep on dividing, your cells will keep on dividing and your telomeres will keep on becoming chota. So as the telomere length will become smaller and smaller is when we will become older and older. That is the theory of aging. But what is the concept of telomerase? Telomerase is an enzyme that is going to inhibit the shortening of the telomeres. So now just imagine if someone is very lucky and someone is born with a lot of telomerase, just as an example, this means that person will become Amar, that person will become immortal and will live for like what, 200-300 years then in that situation. But then now understand, increased telomerase activity क्या करता है? Telomerase is something that makes us immortal. Will it then be associated with becoming old? No. If they would have written increased telomerase activity is associated with immortality, then this would have been a correct statement. So simple concept. ओल्ड होने में क्या हो रहा है? टीलोमेयर्स आर बिकमिंग छोटा, टीलोमेयर्स आर बिकमिंग छोटा. एंड इमॉर्टल में क्या हो रहा है? इमॉर्टल में इज ओनली व्हेन समवन हैज एक्सेसिव अमाउंट ऑफ टीलोमेरेज एक्टिविटी. एंड नाउ फ्रॉम हियर नेक्स्ट PYQ जो आया, व्हाट डू यू थिंक कैंसर सेल्स हैव? कैंसर सेल सोचो, डोंट थिंक ऑफ यू गिविंग कीमोथेरेपी, जस्ट थिंक ऑफ कैंसर सेल. Cancer cell is deadly. Why is it so deadly? Why is it that cancer keeps on growing till you don't give chemoradiotherapy? This means the cancer cell has also read general pathology. Cancer cell knows कि मुझे तो immortal रहना है. I don't have to get killed. This means I will have to increase what? Cancer cells say we will increase our telomerase activity and that is how we will live forever and ever. Is that okay? These two statements, they will only play with language of telomere and telomerase. That's all that you have to pay attention to. I think let's move forward to the next question that we have over here. 56-year-old male patient. I think this buzzword, every time it comes in the exam, it makes me very happy, but students start getting very panicky because ye kya aaya? Dragging sensation in the abdomen. What does that mean? Pulling the abdomen down, they are talking about massive spleen. Now massive spleen can happen because of a million causes. But जब 40 days जब रहते हैं तो let us go very पेशेंट को थोड़ा साइड रख के MCQ पॉइंट ऑफ व्यू से सोचें. तो मैसिव स्प्लीन मैम ल्यूकीमिया का होगा तो CML या फिर hairy cell leukemia. These two things you think of. And when they talk about infections, I will think of काला आजार. अब यहाँ पर ये तीन चीजें तो immediately should pop up in your mind when they say massive spleen. As they said, hyperleukocytosis, platelet count is increased and everything is about white blood cells. I'm like, okay, kala azar is out. This is something to do with one of these leukemia lymphomas. And then they say myeloid cells are mixed population with myeloblast, myelocyte, metamyelocyte, neutrophil, basophil, मतलब college girl or garden party appearance. So many different cells. No one will tell you label karo cells ko, no, but at least with your basic understanding, you know every cell looks different. हर एक सेल दूसरे से अलग है. This is a case of CML, and CML के लिए we will no points for even guessing that it is going to be a case of Philadelphia chromosome BCR-ABL. So now they will ask you that, okay, what is the investigation of choice for any chromosomal disorder? What is investigation of choice? It is going to be FISH. So we will have this. They will mention color coding. आपको नहीं याद करके जाना. Color coding of FISH always examiner will give. So 2 copies of BCR over here, 2 copies of ABL over here. So I expected the same 2 copies, but then I noticed that there is a classical translocation between this happening. This is a case of translocation 922. Does that always make it CML? Is my question to all of you. Translocation 922 अगर लिख दिया examiner में, will you not read anything else and mark it as CML, or no? You will ask me what is the weight of the fusion protein, and listen to this carefully for NEET. You've done it even in your rapid revision videos. As soon as they write BCR ABL, you're like, क्या weight है? Examiner will write 3 weights for you. 190 kilodalton, 210 kilodalton, or 230 kilodalton. They are just at intervals of 20-20. And then you have to go as LMN, which means if it is 190 kilodalton, it is a case of ALL, not CML. Only when it is 210 kilodalton will it be a case of CML. And if it is 230, which is a very controversial entity, but that is chronic neutrophilic leukemia. Chances of them asking you CNL because वो वैसे ही controversial है, नहीं पूछेंगे. But them asking you these two is there, and now they might go one step ahead and ask you, not a PYQ till now, but you never know this exam, prognostically क्या difference है? See, both of ALL may be, CML may be, translocation 922, same BCR ABL is happening, but in one of them the weight is 190 kilodalton of that protein, one is 210. When it is CML, this 210 Philadelphia chromosome actually has a good prognosis for the patient, but ALL में जब same चीज होती है, that carries a bad prognosis for the patient. So now they are going more into clinical integration, right? So they might not just ask you कि weight क्या है, क्या diagnosis है, they'll ask you the impact on the patient that it will have, which I think is settled for all of you. Yes. Now, yeah, 190 is bad. Most of you got that right, which I believe is perfect for everyone. Great. So LMN, ये याद रख लेना, because but what you've understood is इनमें से कुछ भी हो, सब में हुआ क्या है, translocation 922, सबका जो investigation of choice होगा, that is going to be FISH. Please don't ask me questions on CNL for those who are, because this is anyway in hemat, as even as a pathologist, this is a very controversial entity. They are considering it as a spectrum of other diseases. 40 days into the exam, I don't want you to get into all of those controversies. It is not at all important for you. Okay, moving on to what बाकी के options भी बता दो. 8, 14, 8 and even number Burkitt's lymphoma. What is this 15, 17 that I had to mark? This is that DIC वाला कौन सा leukemia होता है, AML M3. So I think this also you know. And then again another 8 and even number. This also goes in favor of Burkitt's lymphoma. This you knew. Let's move on to the next question. There is a 10-year-old child with pain in the bone, and the bone shows some sclerotic changes. Classic PYQ है. Peripheral smear के साथ bony pain lesion दिया. Anyway, see, whenever this 10 to 14-year-old वाला बच्चा comes with bone pain and they try to link it with hemat, I only think of one disease, that is sickle cell anemia. If I wanted to get this confirmation done, I can see classical sickle cells over here. Sickle cell को actually में hemat में क्या बोलते हैं? They will not write sickle cell ना, ये तो दिख रहा है. They will write the other name of it, and that is known as drepanocytes. Remember this, the word drepanocyte is written. And now they say the most common organism implicated in osteomyelitis. अगर सिर्फ ये one liner होता, my answer would have been Staph aureus. The most common organism for, or most common cause of osteomyelitis is Staph aureus, but the most common cause in sickle cell anemia is salmonella, and that is the answer over here. कौन सा salmonella? Salmonella typhi, typhi murium, paratyphi A, paratyphi B, enteritidis. कौन सा वाला salmonella is the next question. So remember, it's salmonella enteritidis. That is the one that is the most common cause of osteomyelitis in sickle cell anemia. और कैसे ये question आ सकता था? If they didn't want to be so obvious, they don't want to give you this Then they'll give you hemoglobin electrophoresis. Now I know I'm going off track, but hemoglobin electrophoresis, can you revise with me? Because I mean, why should we leave everything to, I know I'm using again something that will keep you off track, but LRR के लिए सब कुछ नहीं छोड़ते ना. हाँ, LRR होगा. Before that question starts coming up and it's in the first week of August when it's starting, तो वो उस track में मत जाना, but everything we won't leave for LRR. Something we'll do here also. So now when I say HB electrophoresis, there are 2-3 possibilities that we get. If they say that the sickle hemoglobin is excessively present, excessively matlab 80, 85, 90, 95%, I'll say okay, it is a case of sickle cell anemia. If they say there is a combo of these two, 50% adult hemoglobin, 50% sickle, या 40-60, almost equal, then you will start thinking of sickle cell trait. यहाँ तक तो मैम हम कर ही लेंगे, this is obvious. If I say the HbA2 levels are more than 3.5%, right now you told me it is a case of thal trait or thal minor. Can you tell me when is it a case of thal major? Now that's what I want you to actually learn before you forget that. ये revise करना है. थैल मेजर कब होता है? मेजर मीन्स दैट बीटा चेन्स आर नॉट फॉर्मिंग. अडल्ट हीमोग्लोबिन तो ऑलमोस्ट बन ही नहीं रहा. सो द बॉडी एज अ कॉम्पनसेशन स्टार्ट्स मेकिंग फीटल हीमोग्लोबिन. रिमेंबर दिस, मतलब दिस इज वॉट स्टूडेंट्स टेंड टू फॉरगेट इन द एग्जाम. बाकी सब तो कॉमन सेंस से हो जाता है. फीटल हीमोग्लोबिन मोर देन 90%, स्टार्ट थिंकिंग ऑफ थैल मेजर. I think going off track, but coming back, sickle cell anemia, osteomyelitis, that is settled. Moving on to another, अब 2-3 ऐसे quick वाले questions PYQs revise कर लो. There is a histopathology shown of an ulcerated nodule at the tip of the nose, very tiny. What is the diagnosis? This is a classical location कि या तो medial canthus होगा या फिर near the tip or somewhere near this nose and this cheek area. And what all will you think of? I could think of any of these practically, but when I saw the photo is not a good picture. But I thought that why should examiner have all the fun? We should also give blurred photos, prepare you beforehand before the examiner throws blurred pictures at you. So maybe you can't understand whatever nonsense is happening here, but एक चीज आपको ढूंढना पड़ेगा. Clinically, if all of you started thinking of basal cell carcinoma, what is that one finding? Ma'am, whatever tumor cells are there, around the tumor cells, can you see कुछ तो white जगह बना है, and that is known as retraction artifact. Basal cell carcinoma or rodent ulcer, whatever you want to call it, the cancer cells are all parallel to each other. वो तो दिख ही नहीं रहा. That is known as peripheral palisading. But around the cancer cells there is a retraction. Just imagine this hand of mine is cancer cell. Okay, ये सारे cancer cells हैं. One option was cancer cells are stuck to normal tissue. Second option is cancer cells say that no, we are the VVIP, we will stay away from normal tissue. That is what it does. Cancer cells say we will stay away, हम एक gap बनाएंगे, normal अलग, cancer अलग. So that gap is known as retraction artifact, and that's the main thing that you have to see for basal cell carcinoma. Why do you call it a rodent या rat? Because where did it happen? Over here, tip of the nose या medial canthus, जहाँ पर भी हुआ. Will it spread to the lungs or the liver or the bone or the brain? Or this cancer says, I will keep on growing like a rat, I will keep on destroying the face. Basically, it's the rat philosophy. So, local invasion is what it's preferring. But बाकी सारे cancers तो love to show metastasis. All cancers say that everyone likes foreign travel. तो all cancers say कि हम तो brain में भी जाएंगे, lungs में जाएंगे, liver में जाएंगे, bone में जाएंगे. But there are two cancers which say no, we don't want to travel internationally. हमें domestic, हमें locally ही जाना है. One cancer is basal cell carcinoma. It says I will only grow on the face. And the other cancer is brain tumors, or you want to call it glioma, जो भी. Brain tumor में brain में ही grow करता रहता है. Very rarely you will see brain tumor comes down to the liver or something like that. Very rare situation. So BCC and brain tumors, where they are, they like to travel only there. They don't like metastasis. Another general path, one-liner PYQ done. Moving on to the next question that we have. Here I have hidden a part of the question. पहले hidden way में बता दो, then I'll reveal whatever was written in the PYQ. In a patient with raised LDH, elevated bilirubin and hemoglobinuria, what have you started thinking of? RBC lysis should definitely come to your mind. RBC break हुआ तभी तो hemoglobin is coming out into the urine. RBCs breaking, that is why the hemoglobin is converting into bilirubin, jaundice hoga patient ko, tabhi the RBC enzymes are coming out. So all of this is going in favor more of intravascular hemolysis, that the blood is breaking and all of this is happening. Peripheral smear shows you something. Jab PYQ aaya tha, it was written, I replaced it with a photo. Can you identify what this is? These are broken RBCs. This is schistocytes. Schistocytes kya hote hain? They are known as fragmented red blood cells. So they are broken in so many shapes. Sometimes they write helmet cells, sometimes they write cap cells, alag alag tota futa shape mein hua hai. This is a case of microangiopathic hemolytic anemia. So now what do I mean by this? So is this an enzyme defect? क्या ये कोई G6PD deficiency है? No, because G6PD deficiency में कौन से वाले cells दिखते हैं? Bite cells दिखते हैं. So this is definitely ruled out. Is this a case of hypersplenism? Again, schistocytes happening doesn't make sense. Thyroid dysfunction, very random statement. This is mechanical heart valves, prosthetic heart valve, what they want to probably write it as. Prosthetic heart valve is something like, imagine when the, just imagine like a stone, a very solid thing, and the blood crashes into it and the blood breaks. So anything like that is sitting like a stone in your path, when the blood will hit it, it will break. So let me just make a random blood vessel, and मान लो यहाँ पे किसी भी reason से एक obstruction है, or there is something different from the normal body. That could be a prosthetic valve, that could be maybe just a blood clot, maybe it is a case of hemolytic uremic syndrome, maybe it is a case of TTP, maybe it is a case of DIC, या clotting का कोई भी problem है मैम, clot तो बन गया ना. Now when these RBCs are flowing and they will crash into it, these RBCs will end up breaking, तभी बना schistocytes or fragmented RBCs. So that could be because of a heart valve, that could be HUS, TTP, DIC, कोई भी reason जो clot बनाएगा, these poor RBCs will crash into it, will break, and that is the reason for schistocytes shown over here. Is that okay with everyone? If I had to correlate this with our previous session, hemolytic uremic syndrome is associated, ये तो पता लग गया that मैम hemolytic उसके तो नाम में ही है, hemolytic anemia, schistocytes, understood. Which was the bacteria that can cause hemolytic uremic syndrome? A very classical one. E. coli का कौन सा वाला? That is EHEC. कौन सा strain? That is what I want to ask you. O157H7 is the question they ask you so often in the exam. Most of you know it. Very good. Smart people. Moving on to the next question that we have. This came in the recent FMG exam. INI also. दोनों में कुछ इस पे touch upon हुआ. NEET PG has always tested. Familial HNPCC, hereditary non-polyposis colon cancer, is a defect in. What a simple question, ma'am. तो ऐसा क्वेश्चन आया था? नहीं, ये तो आपका नीट पीजी PYQ है, बट दिस टाइम these two sessions in the previous have just gone way too lengthy, right? And you guys, most of you did give INI, you got through that. Even in FMG, what is this known as? This is known as Lynch syndrome. So obviously Lynch syndrome में 3 cancers होते हैं, and they gave you a clinical history of it. Number 1 is colon cancer, which is written right in front of you. The other one is endometrial cancer, and the third one is ovarian cancer. And there will be a family or a clinical history of these CEO cancers given, and then they will ask you it is a defect in what? Mismatch repair. But I think now, since this has already been tested, they will ask you what are the names of the MMR genes. पहले तो उनके नाम बताओ, and second, what exactly is the pathophysiology? They will go one step ahead. So firstly, I'm sorry, I don't want you to learn these names, but you will have to, and we've done this in our video lectures. 5 naam aapko, whether you like it or you don't, you will have to learn them, because some ratification will always be needed for the exam. When I say MMR genes, first you learn it as MLH1, MSH2 and 6, and PMS 1 and 2. तो आप इनका सिर्फ MLH, MSH, PMS भी याद कर लो. Maybe numbers are not very important, but these 3-4 genes, they are all known as MMR genes. When they stop working, what is mismatch? इसका मतलब क्या होता है? Because normally I know the body works on what? ATCG, ATCG. Till the time it is ATCG, ATCG, everything is fine. But if there is a mismatch, मान लो AA हो गया, TT हो गया, then who will come to protect me? The mismatch repair genes will come to protect me. Till they are protecting me, you and I, we are sitting over here attending PYQ challenge and we are fit and fine. The day they stop working, the chromosome will become unstable, and that is known as MSI. माइक्रोसैटेलाइट इंस्टेबिलिटी, इसकी वजह से होता है हमारा HNPCC और लिंच सिंड्रोम और whatever you may want to call it, and that is when the patient goes into these three cancers. And why am I saying family history hoga? Because what is the inheritance? It is a part of autosomal dominance. So they will say one of the two parents, mother also, probably mother also had one of these, or father also had something. So kuch familial will also be mentioned in the exam. Right? Moving on to the next question. Are we ready for it? Let's start. Which of the following is seen in the biopsy of a patient who had a post-MI reperfusion injury? I think till now, even in INI-CET, MI के ऊपर autopsy findings, I think they've asked you so many times. And you know all that TPTC wala stain and all that is understood. But what else can they ask you from their PYQ now? Now the trending topic will be after MI, the first thing that you do, either you open the blood clot or you do an angioplasty. Basically, you want to reperfuse the patient. Reperfusion की वजह से क्या इंजरी होता है? Amazing. It is contraction band necrosis, which is the answer. This is what is expected. So होता क्या है reperfusion injury? They might want to go into the detail. Sorry for the very baby juvenile diagram that I'm drawing, but just imagine if this is the coronary artery that is supplying the heart and uske andar ek atherosclerotic plaque hai, so obviously the blood supply got blocked. That is why patient had MI, angina, heart pain. Now when you are opening this, just imagine when this blood clot was there, what was getting accumulated at this site? Sare free radicals, calcium, it was like a roadblock. All of them were getting accumulated here. Now you started deciding कि चलो let me open this blood clot. Thrombolytic therapy or angioplasty करा, तो open करने पे क्या हुआ? All these free radicals, all the calcium ran to the heart. What will free radicals do? So much of free radicals ran to the heart, तो मैम injury होगा. And so much of calcium तो causes contraction. So much of contraction will happen all of a sudden. Imagine all of a sudden the heart muscle contracts, it will end up dying. That is why contraction band necrosis occurs. And look at this picture which they might want to give you. This is the only image they have of CBN, contraction band necrosis. Can you notice there are these bands of dead cardiac fibers? ये हैं वो pink color के bands. This is known as contraction band necrosis. All good. And if by chance, I mean again not expected, but ऐसा कुछ आ जाता है कि reperfusion injury, the injury component is more because of free radicals or calcium. I mean if there are two separate options, I can expect anything happening now, right? So I'm preparing you for worst case scenario. अगर हो जाता है, so the single best answer of what is more deadly, more dangerous is always free radicals because they are harming all the more. Okay, moving on to the next question. Changing organs, going into more of systemic, little bit of medicine. 20-year-old patient with history of malabsorption, diarrhea and poor appetite. At least with malabsorption, 2-3, as I said, think of it like a patient को MCQ में fit करना है. So क्या क्या हो सकता है? 2-3 main things coming to my mind, like within 5 seconds it has to strike me. Malabsorption में या तो ये Whipple's वाला है, Whipple's का bacterial infection है, या तो it is that gluten वाला problem, or it is some microbiology का some parasite that they will give me. When I started reading, they did a duodenal biopsy showing me all these features. They have not mentioned any keeda, parasite, nothing. So at least the micro part is out, and this is core of celiac disease exactly, or the gluten sensitivity that they are talking about. This is not Whipple's. पहले तो क्यों नहीं है? Whipple's होता तो what is the finding that they would have told me? Pass positive macrophages in the lamina propria लिखा होता, which is not there. This is not inflammatory bowel disease. I mean this is not Crohn's or ulcerative. Crohn's होता तो what would have been the hallmark? Non-cageating granulomas होते. Ulcerative colitis होता तो मैम maybe pseudo polyps would have been mentioned. So in pathology they have gone for duodenal biopsy. Why? Because in celiac disease, yes, the patient has diarrhea. The maximum impact is on the duodenum, and इसी वजह से along with diarrhea the patient also has iron deficiency ना, because duodenum is where we absorb iron from. If iron is not absorbed from the duodenum, duodenum पे damage हुआ, duodenum पे क्या damage हुआ, that is what they ask you in medicine. What is the criteria for celiac disease? क्या है celiac disease? Gluten का problem. Those baby questions I'm not asking you कि bro cereals के नाम बताओ. barley, rye, oat and wheat. When someone has these, that is when this problem starts. But that we also eat, we don't have a problem. Why do these people have a problem? Because they are also having which HLA polymorphisms exact पूछेंगे. HLA DQ2 DQ8 polymorphism की वजह से these are the people who cannot tolerate barley, rye, oat and wheat. तो क्या problem हुआ? Whenever they ended up eating this whatever bro cereals, they ended up making IgA type of antibodies, and now these IgA antibodies will go and attack. Can you see इन्होंने villi को जाके attack करा. So what happened to the villi? The villi went flat. That is known as villus atrophy. Someone is coming and attacking you, you will fight back. So if villus is getting atrophied, can you see what happened to the crypts? The crypts have started becoming angry that, oh, how are you damaging me? Can I say there is crypt hyperplasia happening? And inflammation to hoga hi, so there are inflammatory cells noted. इसे क्या बोला जाता है? This is known as Marsh criteria for celiac or the gluten disease. Obviously now you will ask me that ये IgA antibody same वो gluten की वजह से जो बना intestine में तो Marsh criteria करा दिया, and that's fine, but this also goes on to the skin. These antibodies go and damage the skin. Dermatitis herpetiformis can happen, and dermatitis herpetiformis का treatment क्या होता है? That is going to be dapsone. So they might ask you a history of gluten in dermatology with dermatitis, or they might ask you which is the antibody getting deposited in the skin in dermatitis herpetiformis. You will say IgA. IgA ही celiac का problem करा रहा है, IgA ही dermatitis करा रहा है. Everything fixes well over here. I think this is done. Dapsone भी सबने बता दिया. Perfect. Moving on to the next question. 20-year-old patient presented with swelling in the wrist joint for 2 years. Not too many questions regarding wrist joint. Wrist joint से या तो carpal tunnel syndrome आता है, or they've given me some swelling, so I'll have to read further. क्या और क्या हो सकता है? Palisading spindle cells with verruca bodies. वेरी क्लासिक PYQ. तो इस पे तो नहीं आने वाला क्वेश्चन. वेरुके बॉडीज के साथ ऑफ कोर्स इट इज schwannoma. क्वेश्चन कहाँ आएगा इज व्हाट आई विल आस्क यू. सो व्हेन यू से वेरुके बॉडीज, आई थिंक यू कैन सी दीज वेरुके बॉडीज ओवर हियर, बट आई हैव वन मोर पिक्चर ऑफ schwannoma. डू वी ऑल नो द टू एंटनी एरियाज? एक है एंटनी A एरिया, एक है एंटनी B एरिया. एंटनी A एरिया हैज अ लॉट ऑफ सेल्स, so many cells. एंटनी B area is बिल्कुल blank, so I can see खाली blank. They will ask me nowadays the immunohistochemical marker of schwannoma, and that is S100. Now S100 is the most useless marker that I have. How we as pathologists learn it is that S100 is positive in 100 tumors. हर जगह S100 positive आता है. तो S100 alone will never tell me that हाँ पक्का schwannoma है. पक्का schwannoma के लिए you will have to look at this, the Antony A, Antony B and verruca. But हाँ, if they ask you IHC marker, it is S100. Further, if they want to ask me what is the syndrome, that is schwannoma का syndrome NF2 का chromosome, that is chromosome 22, and then they will ask you what are all the different tumors that occur in NF2 और chromosome 22 के साथ. एक तो multiple schwannomas, वो तो मुझे समझ आ गया, but other than that tell me some brain tumors. Which one do you think of? Meningioma, very good. Miss me तो सबने बता दिया. Tell me the full form of miss me, otherwise you will be missing this mnemonic only in the exam. तो multiple schwannomas तो obviously NF2 का नाम ही schwannoma है. M for meningioma and E for ependymoma. Perfect. These are the other questions of NF2, and something might come because if you remember in the recent INI only you were given a question on neurofibromatosis. Over there the patient had cafe au lait spots and leash nodules. तो NF1 पे question आया था. So maybe they will want to test you on NF2, and that has always been a gold standard question for every exam. Okay, moving on to the next recent question again. This came in the FMG. Has been asked in NEET PG. अब कुछ जल्दी वन लाइनर्स कर लेते हैं. ट्यूमर सप्रेसर जीन P53 causes cell cycle arrest at. My first question, cell cycle का normal sequence बता दो. G1S, G2M. Someone said shagreen patch. Are you confusing neurofibromatosis with tuberous sclerosis by any chance? I may be very bad at dermatology, but मुझे जितना याद आ रहा है, the ash leaf spots and the shagreen patches, they are more going in favor of the hamartomatous वाला syndromes, that is tuberous sclerosis, TSC1, TSC2. TSC1, 2 and tuberous sclerosis is different, and NF1, 2 and neurofibromatosis, they are totally different. Alag chromosome, alag gene, alag syndrome that we have, right? So don't confuse both of those. Coming to the next. पहले तो normal बता दिया, G1S, G2M, this is how the cell cycle works. Where are the cell cycle arrest करने के लिए? I mean checkpoint होगा, checkpoint पे पुलिस होगा, तभी arrest होगा. So what are the two checkpoints? One is at the junction of G1S, one is at the junction of G2M. They are asking you tumor suppressor gene P53. P53 क्या है? हमारा policeman. Ma'am, policeman has to be present at every check post. तो policeman will be present at the first check post also. Policeman will be present at the second check post also. क्या दोनों दिए हैं options में? नहीं, options में मुझे सिर्फ G1S दिखाई दे रहा है, which becomes my easy वाला answer. The problem is that what if both would have been given? One option would have been G1S and one would have been G2M. दोनों में ही P53 needed है. Then what would you guys have marked? तब क्या mark करते हैं? Both is not there in the options. Option A, option B. तब क्या mark करोगे? Because I'm preparing you for horrible scenarios, which should not be asked, but examiner कुछ भी पूछ सकता है ना. So in that situation, single best answer will be G1S if that situation arises. My next question, instead of P53 gene, if they would have written RB gene works on which phase of cell cycle? It works on G1S. Can I say G1S is the main phase? The policeman works more over here, the RB gene works more over here. G2M वाला phase कौन control करता है? That is done by P53 gene. Okay, so P53 both places, RB gene only the first checkpoint. And why is it that the cell cycle always works G1S, G2M, G1S, G2M? तो वो कौन से cyclins थे? That I just now told you. It is cyclin धोनी, एक अच्छा batsman, D, E, A, B. And that is now, do cyclins work alone? It is only D, E, A, B, D, E, A, B ऐसे चलता रहता है in the cell cycle, or the cyclins work with some CDK numbers which you can never forget. धोनी के साथ it is always 4 and 6. That's how the scoreboard goes. And with others it is double, double, single. So cyclin D works with CDK4 and 6. Cyclin E works with CDK2. A works with CDK2. B works with CDK1. ऐसे मुझे नहीं याद रहेगा. Better is I learn DEAB and I learn the scoreboard, and that is going to be easier for me to understand in the exam. Perfect. And अगर यहाँ से लेते लेते they take you into hematology, they will say, can you tell a disease where cyclin D1 is overexpressed and which lymphoma was it? अभी पढ़ा था mantle cell lymphoma. कौन सा translocation? It is 11-14 translocation. So how from cell cycle they can go to lymphomas? Intra-subject integration can also happen. Every time integration doesn't mean कि path के साथ medicine ही होगा, gynae ही होगा. They might go from general path to hemat. So intra-subject के लिए also you should be prepared, which figures this out for us. And coming to the next question, 48-year-old chronic smoker with difficulty in breathing. Till now I thought it is like smoking, breathing. मेरे हिसाब से this could be maybe COPD, emphysema, bronchitis. Let's read. There is improved by pursed lip breathing and weight loss. I think I was on the right track. I am thinking of some COPD. Then they say CT chest image is shown, and I think that has not come up over here. I'll see if I can, I don't know, it's hidden, but आगे पढ़ लेते हैं. I believe it can be done without that also. The condition is associated with alpha-1 antitrypsin deficiency. So I don't think I need the CT, although when I'll share the PDF, I'll make sure I paste it again. But now tell me, the gene coding for alpha-1 antitrypsin is located on chromosome. तो इतना भी question पूछ लेते तो मेरा काम हो जाता मैम. I still know it is chromosome 14 because this has been a previous year question. Twice it has come. या तो clinical आएगा या फिर it will come as a one-liner. One-liner is this. Alpha-1 antitrypsin ka you let us know that what is the chromosome. It is chromosome 14. Now my question is, what is the name of alpha-1 antitrypsin? तो enzyme का नाम है. What is the name of the gene for alpha-1 antitrypsin? It is the SERPINA gene. It is the SERPINA gene, that name of the gene. So do you know why am I focusing so much कि इस gene का मुझे नाम बताओ that is present on chromosome 14? SERPINA will tell you that it is a protease inhibitor. Please note this because अब आपसे थोड़ा concept पूछेंगे. Protease inhibitor is the function of alpha-1 antitrypsin. That is why whenever you see the report of a person, it will be written as that person is PIMM, or it will be written as person is PIMZ, or it will be written as PIZZ. तो मैम ये PI क्यों लिखा होता है? Because PI means it is alpha-1 antitrypsin का testing done, it is protease inhibitor का testing done. Now tell me, if it is PIMM, what will that mean? That you are a normal person and you have normal alpha-1 antitrypsin. कोई deficiency नहीं है, कोई disease नहीं है. If you are PIZZ, this means that you are a diseased person that you're dealing with. Diseased मतलब alpha-1 antitrypsin deficiency है इस patient को. But if you are little bit of normal and little bit of diseased, then that means it is alpha-1 antitrypsin का trait. trait bola matlab what is this inheritance that you have? Alpha 1 antitrypsin is an autosomal recessive disorder. Ideally autosomal recessive disorders tend to occur as 4 or 8-year-old छोटे बच्चों में होता है, but over here they wanted to give me an adult and that is the examiner's choice on what he wants to do. But my question is that अगर किसी को disease है, what are the 2 organs that are going to get affected? Lungs, वो दिख ही रहा है that we have emphysema. Can you tell me which type of emphysema? pan-ACNR, very good, all of you are right. But second, liver भी affect होता है and liver में cirrhosis can happen. I mean in a 48-year-old cirrhosis is still understandable, but imagine 4-year-old में भी हो सकता है, 8-year-old में भी हो सकता है, because ideally it's an autosomal recessive disorder and it starts early in life, childhood onset होता है. So these 2 are the main organs which you will think of when we talk about alpha 1 antitrypsin deficiency. pan-ACNR emphysema is also a PYQ. Past में पूछा गया, अच्छा which kind of emphysema happens with alpha 1 antitrypsin deficiency? Then you should know pan-ACNR. Next question will be कोई special stain बता दो for alpha 1 antitrypsin. Now that you've told me everything, I'm just completing the topic. It is PAS positive. Alpha 1 antitrypsin deficiency, PAS positive. Okay, now coming to, should I ask you one logical question? Alpha 1 antitrypsin का deficiency है, the enzyme is missing. एंड यू आर सेइंग द स्टेन इज कमिंग आउट टू बी पॉजिटिव. मैम जब कुछ मिसिंग होता है तो वो तो है ही नहीं बॉडी में, देन हाउ इज द कलर कमिंग आउट टू बी पॉजिटिव? दैट इज नॉट मेकिंग सेंस. कैन एनीवन गाइड मी ऑन दिस के पास हाउ कैन कलर कम पॉजिटिव व्हेन द ऑब्जेक्ट इज ओनली नॉट देयर इन माय बॉडी? इसका क्या लॉजिक है? व्हेन आई से अल्फा 1 एंटीट्रिप्सिन डेफिशिएंसी, डज इट ऑलवेज मीन that level has decreased, or sometimes it means that if 5 molecules होने चाहिए थे, now also I have 5 molecules but they are not working properly. Please note that lung में जो problem होता है is because alpha 1 antitrypsin genuinely quantity में कम है. That is why the emphysema वाला problem happens. But do you know liver का problem is that alpha 1 antitrypsin is actually not working properly. It is misfolded. मतलब if 10 molecules had to be there normally, now also 10 are there in the liver, but they are not working, they are useless. And that is the one that is coming out to be PAS positive. So they might ask you that enzyme तो deficient है as per your name of the disease alpha 1 antitrypsin deficiency, then PAS positivity का logic क्या है? That actually it's not deficient, it is a misfolded protein and that has taken up the PAS positivity. So if logic is asked, I think that is also settled for you. Moving on to the next question. Just a second. Yeah, this I picked up from your rapid revision videos कि अगर पढ़ा है तो anyway you studied this with me. The mutation seen in Cowden syndrome is associated with which of the following carcinomas? Their favorite type of tumor questions where lots of tumors are there and then you have to pick up one, and I'm sure you've done this in the RR videos का also. If you've seen the PYQs, you have settled this. तो क्या क्या होता है? What is Cowden? How can you forget den? मतलब P10 is the name of the gene. It is present on chromosome number 10. P10, chromosome 10, and the syndrome that it causes is Cowden. क्या क्या होता है Cowden syndrome में? Again you learn it by the name P10. So let me go in this. Number 1, what happens? Endometrial cancers happen. तो एक option तो tick mark. Next, what happens? Thyroid cancers happen. Next option is also tick marked. What next with T? T से दो चीजें होती हैं. There is one skin appendigeal tumor. Can you tell me कौन सा? Hair वाला, tricholemomas. Tricky means hair. तो yes, this is also correct. And what am I left with? GIT में क्या होता है? Polyps होते हैं मैम. Lots of polyps in the GIT. GIT के दो polyps बहुत famous है. एक तो वो Peutz-Jeghers वाला polyp which you know. One is this Cowden syndrome वाला polyp. And the other one, because we could not make anything out of this mnemonic, we had to make it as breast cancer, which tells me that this was more of a learning question कि ये सारी चीज़ें होती हैं. Polyps and breast cancer होता है, thyroid tumor होता है, tricholemoma होता है, endometrial cancer होता है. तो आई थिंक वेन एवर विद एंडोमेट्रियल कैंसर दे वॉन्ट टू गिव यू सिंड्रोमिक एसोसिएशंस ना, तो या तो एंडोमेट्रियल का P10 और काउडेन के साथ आएगा या फिर एंडोमेट्रियम विल कम इन दैट HNPCC या लिंच सिंड्रोम वाली स्टोरी. दीज आर देयर 2 फेवरेट एंडोमेट्रियल सिंड्रोमिक एसोसिएशंस दैट दे लाइक टू गिव यू. Moving on to the next question that we have, easy one again. What is the anticoagulant that we have for coagulation study? साथ में मुझे vacutainer का color भी बता दो. Coagulation is what? PTA, PTT studies that you have. For that we use the light blue vacutainer. So not just for PTA, PTT study, even if you're doing ESR estimation by Westergren method, then also you use the light blue vacutainer. क्या होता है उसमें? Very good it is. Blue तो ठीक है, but tell me the option. What is the Done. It is trisodium citrate. Yes, trisodium citrate is the one that I use. Now my question is ke ESR by Westergren to you do over here. This means there will come a question that ESR is also done by another tube called the Wintrobe tube. Wintrobe tube में अगर ESR हो रहा है तो कौन सा anticoagulant use करेंगे? We will use EDTA. EDTA is which one? It is the lavender or the purple Vacutainer. So I'm telling you beforehand, whenever we come to the LRR in the first week of August, and I have kept the Path LRR early only, the first week of August. So the last slide of that LRR will be all color-coded Vacutainers, जो एक बार तो हमें revise करने ही करने हैं. There is no doubt about it that once you will have to do it on your own, once you will do it with me. So all these Vacutainers will be coming again without a doubt. Okay, this one line is also done. Let's move on to the next one. Jaldi wale questions we are coming to. This is something which I've seen students skipping maximally. When I saw the Q bank, I came to a conclusion कि सबसे ज़्यादा skip rate इस वाले question का था. So I thought I'll pick it up. Myelodysplastic syndrome, because this is something we don't have in rapid revision videos. Medicine में है, but then maybe medicine you're not reading from hemat perspective, so you tend to skip this. Myelodysplastic syndrome, the image shown below shows the involvement of which organelle. So this is an image shown below in myelodysplastic syndrome. Which organelle is involved? Tough question for sure, but many of you are saying mitochondria, some of you are saying endoplasmic reticulum. ठीक है. So now what is myelo? Myelo का मतलब you understand something to do with bone marrow. Okay. And dysplasia you understand from general path. Dysplasia means this has a very dangerous pre-cancer potential. मतलब मैम later on myelodysplastic syndrome कुछ तो leukemia lymphoma में change होने वाला है. Some cancer event is going to happen beforehand. But right now you are saying the pre-cancer is in myelo. Anything in the bone marrow. बोन मैरो में तीन चीज़ें होती हैं, रेड ब्लड सेल, वाइट ब्लड सेल एंड प्लेटलेट. दिस मीन्स एनी ऑफ दीज थ्री कैन हैव चेंजेस. Most commonly they ask you the changes in the red blood cell, and that is known as the ringed sideroblast. What is ringed sideroblast? You understand blast matlab RBC ka precursor. Precursor is always known as blast, so first I will mark this as a precursor. So now let me draw a precursor for you. ये RBC है. Let's make it red in color. Normally do I make a nucleus? RBC में nucleus होता है? नहीं होता. But RBC के precursor में, blast में तो nucleus होता है. So let me draw one nucleus over here. प्रिकर्सर में तो है. एंड व्हाट इज आरबीसी मेकिंग? हीमोग्लोबिन. हीमोग्लोबिन के लिए क्या चाहिए? आयरन, राइट? सो वेयर इज ऑल दैट आयरन गोइंग टू कम एंड गेट डिपॉजिटेड? व्हाई डज इट मेक अ रिंग? ये जो ब्लू ब्लू कलर के डॉट्स बन रहे हैं, दीज आर ऑल आयरन एंड दे आर मेकिंग अ रिंग. एनी रीजन? बिकॉज आयरन को किसके साथ बाइंड करना है? आयरन हैज टू मेक हीमोग्लोबिन. तो आयरन एज पर बायोकेमिस्ट्री बाइंड विद, रिमेंबर दैट porphobilinogen, pura pathway of ALA synthase, and finally making protoporphyrin. So ma'am, that final step of that protoporphyrin pathway in which iron has to bind, ये जो final step होता है, ये कहाँ पर होता है? This happens in the mitochondria, and that is why iron will always go and get deposited in the mitochondria, because that's where the final step of hemoglobin synthesis has to occur. तभी वो ऐसे all the mitochondria is around the nucleus. Now you understand why the iron decided to make a ring. And in myelodysplastic syndrome, now you will understand कि ये ऐसे dot 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 वाला ring वाला क्यों बन रहा है. And I have a question over here. Why is the iron looking always as blue color dots? Because this, so you need to know. You've read this in the very first slide of your general path. Even the first half an hour of you studying pathology, you studied this. Because iron के लिए हमेशा एक ही stain use होगा ना, blue color वाला. That is the pearl stain or the Prussian blue stain. That is what they must have used. And now I know the answer to this is mitochondria. I hope now going forward you will not skip this question. कि ringed sideroblast में sidro I understand iron है. Iron is making a ring. Why is it making a ring? Because all the mitochondria is over here. Iron is going and sitting there, and that is ringed sideroblast. Other questions which nowadays they don't ask, because this used to be once upon a time very INI specific topic, but you've told us कि मैम RBC में तो प्री कैंसर के टाइम पे ये वाला चेंज आएगा, WBC एंड प्लेटलेट में क्या आएगा. सो मे बी दीज फैंसी वर्ड्स यू कैन जस्ट गो थ्रू देम वंस. होता है ना कुछ चीज़ें यू कीप इन योर रिमोट मेमोरी कि बस एक बार देख लो एंड यू डोंट हैव टू लुक एट देम अगेन एंड अगेन. सो इन WBCs you see Pelger-Hewitt anomaly. What is Pelger-Hewitt? Let me draw. न्यूट्रोफिल में how many lobes do you draw? कोई भी नॉर्मल न्यूट्रोफिल, एनी नॉर्मल न्यूट्रोफिल is going to have 3 to 5 lobes. But if I say that no, I am only drawing 2 lobes, that is Pelger-Hewitt anomaly. Can I say Pelger-Hewitt anomaly is a hypo-segmented neutrophil. Is that making sense? I will not write this, but you will tell me. Tell me one anemia in which hyper-segmented neutrophils are seen, that is B12 deficiency. Over here I'm saying hypo-segmented neutrophils, normally 3 lobes, यहाँ पे 2 lobes, so that is Pelger-Hewitt anomaly. And in the platelet, मतलब megakaryocyte, क्या दिखता है? Pon ball megakaryocyte. Pon ball megakaryocyte is a megakaryocyte with these 3 dots. Again, these are not NEET PG questions. That's why I said I've only got these for completion. Main आपको जो याद करना है myelodysplastic में ringed sideroblast. Now you understand every lineage is showing me some trouble. तभी वो trouble को ही तो precancerous event कहते हैं ना, and later on it can result in leukemias, lymphomas, cancerous changes can occur. I hope now this question which I saw everyone was skipping in the exam in your PYQ bank, you will not be doing that moving forward. Can we go on to the next question? Easy one, I believe. 21-year-old woman presents with migratory arthralgia and malar skin rash. ये आते ही with this joint and skin, and especially malar, that butterfly shaped rash. I have started thinking of SLE, and sun exposure है, मतलब photosensitivity is also there. Another thing going in favor of SLE criteria. Urine में RBCs निकल रहे हैं, hematuria हो रहा है, renal, multi-system involvement because it is SLE. Maybe it is lupus nephritis happening. Okay. Serum autoantibodies which have a high specificity over here. Easy question ना, that is dsDNA. तो ये तीनों SLE के question बता दो. Only सबसे sensitive पूछा होता, that would have been anti-nuclear antibody. Most specific पूछा होता, then I would have said anti-Smith antibody. And if they ask you both sensitive and specific, मतलब double benefit पूछा, तो double benefit is by dsDNA. Anti-dsDNA antibody is going to be double benefit. अच्छा, single stranded DNA तो कुछ नहीं होता. What are these two? In which disease do you see anti-centromeric antibody and anti-topoisomerase antibody? Medicine की antibodies also you will have to revise. Anti-centromeric antibody is seen in dermatology का disorder limited scleroderma, and anti-topoisomerase, remember I told you total skin is involved. Total skin matlab that is a case of diffuse scleroderma. Some of you, instead of limited scleroderma, just answered right now as CREST syndrome, and that is also right because CREST syndrome comes to be as a part of limited scleroderma only, तो वो भी anti-centromeric antibody ही है. All of you who gave that answer are perfectly right. Moving on to another PYQ, ये तो इतनी बार देख लिया that what should I ask you in this? Mallory Hyaline body लिखें या फिर Mallory Denk body लिखें, they mean the same. They have told you these are pink color cytoplasmic inclusions that are seen in the liver cells seen in alcoholic liver disease. ऐसा एग्जामिनर ने लिखा, बट आई नो इज इट स्पेसिफिक? हाँ, कैरेक्टरिस्टिक है, बट इज इट स्पेसिफिक टू अल्कोहलिक लिवर डिजीज? नो, इट कैन बी सीन इन नॉन अल्कोहलिक लिवर डिजीज ऑल्सो. इट कैन बी सीन इन विल्सन, मतलब ट्यूमर्स में भी दिखता है, हर जगह दिखता है. इन एवरी पॉसिबल कंडीशन मैलरी हाइलिन बॉडीज आर सीन. They are saying what type of intermediate filament is it made up of? Very good. CK8 and 18. CK क्या होता है? Cytokeratin. एक और बार question आया था. They just mentioned Mallory Hyaline bodies and they said what is it made up of? They didn't write this line. They said what is it made up of? Options में none of this was there. Options में intermediate filament was there. So you should know होता क्या है? What is cytokeratin? Cytokeratin is an intermediate filament, and that is something, in simple words, it's the spine of a cell. It's the vertebral column, the backbone of a cell. वो होता है intermediate filament. One of the examples of intermediate filament is cytokeratin and CK8 and 18. I know this medicine mnemonic everyone knows. Mallory Hyaline bodies are seen in New Indian Watch. क्या है? Can you fill in the blanks with me? What is New Indian Watch? नॉन अल्कोहलिक लिवर डिजीज में भी दिखता है मैम, अल्कोहलिक लिवर डिजीज में भी दिखता है. व्हाट इज इंडियन चाइल्डहुड सिरोसिस में भी दिखता है. आई सी इट इन कॉपर ओवरलोड, दैट इज नोन एज विल्सन डिजीज. It is also seen in Wilson disease. Then it is seen in alpha-1 antitrypsin deficiency also. It is seen in tumors of the liver also. For example, ट्यूमर कौन सा याद आ रहा है? हेपाटोसेल्युलर कार्सिनोमा. एंड इट इज सीन व्हेन देयर इज बाइल स्टेसिस, दैट इज कोलिस्टेसिस. द ओनली थिंग विच आई थिंक आप गलती कर सकते हो एग्जाम में, विच यू शुडंट डू, आई हैव अंडरस्टूड कि इट इज सीन इन द एंटायर वर्ल्ड. वेयर इज इट नॉट सीन इज माई क्वेश्चन. एज स्टूडेंट स्टडी कि अच्छा कॉपर ओवरलोड में दिखता है, दे फील कि अच्छा आयरन ओवरलोड में भी दिखता होगा, एंड इट इज नॉट. सो दे हैव आस्क्ड यू Mallory Hyaline bodies are not seen in which particular condition? They are not seen in iron overload, मतलब hemochromatosis में it is not seen. I think that could be one PYQ which you need to focus more on. Okay, moving on to the next question that we have. I think I've already taught you this. jaldi se bata do. Size of the BCR-ABL protein in ALL is associated in translocation 922. ALL के साथ कौन सा करेंगे? So it is going to be 190 kilodalton. I think I told you how to learn this. LMN. So one last time. 190 kilodalton is ALL. 210 kilodalton will be CML. 230 kilodalton. Not a question, but that will be CNL. So I'll just move forward. एक और about 2-3 one-liners you will tell me. Which growth factor is known as scatter factor? I'm just trying to complete your Q bank from point of view of कि lengthy questions तो starting में कर लिए, but अब one-liners पे भी let's focus because they might twist it and get you a new question. What is known as scatter factor? If you know this, then all clinical questions can be done. Scatter factor का दूसरा नाम hepatocyte growth factor. Hepatocyte growth factor maybe now how the question will come, ये तो हमने रटा लगा लिया. It is hepatocyte growth factor. They will say there is a mutation in scatter factor. Which cancer is the patient at a risk of? So how will you know कि अच्छा scatter factor का नाम क्या था? Hepatocyte growth factor. तो अगर उसमें mutation होगा तो hepatocyte का cancer होगा ना? There is going to be hepatocellular carcinoma. That's why you need to know this fact. If you know the fact, you'll easily be able to apply it. Okay with this, moving on to, I think we have 1 or 2 more quick questions left over here. Patient presented to the OPD with hematuria. Let's get my organ in check. Something to do with, right now I think only kidney. Histopathology showed mesangial widening and endocapillary proliferation, the kind of words I don't like when it comes to renal path questions. Electron microscopy shows some deposits in the mesangium. एक word ऐसा बताओ जो इसमें बार बार आ रहा है. Whatever is happening is in the mesangium. Whatever is happening is in the mesangium. Now let me look at these options over here. Chronic glomerulonephritis is not making sense. Itis, inflammation का कुछ लिखा नहीं है. Let me look at others. When we say MPGN, they should have given me either that tram track appearance, not there. Good pasture syndrome क्यों नहीं है? Because other than kidney, which is the other organ, they should have also mentioned in good pasture lung involvement. Plus good pasture is RPGN. Remember it is RPGN type 1. तो उसमें immunofluorescence में कौन सा pattern दिखता है? Linear pattern. कुछ भी नहीं ऐसा लिखा. They have only focused on one word called mesangium, and that goes in favor of IgA nephropathy. IgA nephropathy is Berger's disease. उसमें IgA कहाँ deposit होता है? Particularly IgA1 goes and gets deposited. Very good, in the mesangium. That is why the mesangium is showing me widening and mesangium is showing me deposits. That one mesangium word. And now I'll tell you 3 questions. This is like your trick in the exam. Kidney के mesangium के बारे में अगर मैम कुछ mentioned हुआ, what are the only 3 PYQs that we have ever seen? या तो IgA के बारे में बात होगी, they are talking about Berger's disease like we are talking about in this question. Or what is the first site of amyloid getting deposited in the kidney? Amyloid general path, amyloid goes and gets deposited where in the kidney? In the mesangium of the kidney. And third question, mesangium में कौन से cells होते हैं? Neutrophils, monocytes, macrophages, basophils, eosinophils. Again go back to general path. What are macrophages of the kidney known as? They are known as the mesangial cells. Like remember, macrophages in the liver are known as Kupffer cells. Macrophages of the kidney are known as mesangial cells. तो अब mesangium से question आया तो या तो simple पूछ रहे हैं कौन सा cell होता है? Macrophage होता है. Amyloid first gets deposited in which part of kidney? Mesangium. IgA कहाँ जाके deposit होता है? अगर glomerulonephritis पूछा तो it is Berger's disease. Okay with everyone? Yes, Dr. San, MPGN कौन सा वाला shows you tram track appearance? That is MPGN type 1, and you are right that MPGN type 2 is dense deposit disease. Okay with all these mesangium questions? Should we move on to the next one? Easy again. 40-year-old female presents with worsening headache since 8 months and a left subfrontal mass is resected. Microscopy shows whirling of the tumor cells and expresses progesterone receptors. Female, hormone dependence and brain tumor. There is only one that you can fit into this story. It has to be meningioma. You all know meningioma में tumor cells का whirling तो लिखा था, but what would have been the more characteristic thing? It would have been psammoma bodies. We know meningioma में psammoma bodies कौन सा calcification होता है? It is a kind of a dystrophic calcification, general path question. And did we right now study meningioma is a part of which syndrome? भाई NF2 में क्या था, मल्टीपल schwannomas, meningiomas and ependymoma. So indirectly they can ask me the same tumor and now they'll write अच्छा meningioma है, this will be written in the question. They'll ask you with which chromosomal abnormality can this be associated. So you should know if it's a part of NF2 then this means the chromosome is 22. That could be another way of asking the question. Moving on to the next question that you have over here. 50-year-old HIV positive man presents with raised purple plaques. This has been the only way of how they've given this question over more than a decade. पर्पल वाइलेशियस प्लाक्स होते हैं इन एन HIV पॉजिटिव पर्सन. एनीवे HIV पॉजिटिव में स्किन के बारे में कुछ आएगा, प्लस दैट स्किन लीजन इज हैविंग स्मॉल वेसल्स, मतलब स्किन का वेसल का ट्यूमर है, ब्लड वेसल ट्यूमर इन एन HIV पॉजिटिव पेशेंट. यू आर थिंकिंग ऑफ कापोसी सार्कोमा एंड देन यू आर थिंकिंग ऑफ HHV8. Going into microbiology again, HHV8 ह्यूमन herpes virus 8, पहले तो DNA या RNA. Herpes viridae family is a DNA virus. Question number 1. Question 2. What are the 3 cancers that HHV8 causes? एक तो Kaposi sarcoma, that is fine, which I can see over here, which is obvious. It is a vascular lesion है, skin का vascular lesion है. In fact, most common site अगर पूछा तो skin. But if I would have asked you the second most common site, that would be the lymph node. This is where all Kaposi sarcoma can occur. Then I know vascular क्यों है, because इतना ज़्यादा red cells है, hemorrhage है, hemorrhage के साथ pigment है, and cancer क्यों है, because so much of division is happening, mitosis is happening, तो Kaposi is on one side. Other than that, as all of you have been writing, it causes one lymphoma. You are right guys, primary effusion lymphoma. तो एक sarcoma हो गया, एक lymphoma हो गया. So you mean to say HHV8 only causes cancer वाला situation? No, it causes one non-cancerous disease also, Castleman disease. When I say non-cancerous disease, तो कौन से organ को involve करता है? It involves the lymph nodes. Which organ does it involve? It involves the lymph nodes, but it is not a cancer. So if lymph node involvement with lymphoma is asked, it is primary effusion lymphoma. If lymph node involvement with the B cell symptoms are asked, which you studied in medicine, like fever, night sweats, weight loss, that kind of symptomatology, you start thinking of Castleman disease. Okay, because you were talking a lot about these, viruses and bacteria, let's ask you one more PYQ on that basis. All of the following have microbial etiopathogenesis except. So what I'll do, I'll just read through them. Let me see if, a virus, bacteria comes to my mind. Burkitt's lymphoma के साथ, yes. 10-year-old African child, तो अफ्रीका में क्या होता है? EBV coming to my mind. Nasopharyngeal carcinoma, that is also Epstein-Barr virus. I will ask you, with Epstein-Barr virus, if they ask you which is the most common carcinoma, पूछा, so that is gastric carcinoma. But if they ask you which is the second most common carcinoma, nasopharyngeal, तो ये भी microbial है. Adenocarcinoma lung, anything coming to your mind? Not coming to my mind, so let's not waste time, let's move forward. Gastric adenocarcinoma, तो of course उसमें तो gastric सुनते ही one bacteria definitely comes to my mind, that is H. pylori. So this is also microbial etiopathogenesis. The one that is not is adenocarcinoma. Adenocarcinoma is associated with mutations, and now can you tell me which mutations? EGFR कौन से वाला? EGFR1 और EGFR2? EGFR1 जिसके अगेंस्ट टारगेटेड थेरेपी भी है ना, erlotinib. So EGFR1. Anything else? How can you forget the Kapil wala KRAS? KRAS में Kapil, colon, pancreas, lung cancer, and even ALK gene mutation, again adenocarcinoma of the lung. Adenocarcinoma lung, ALK आज कहीं first या second slide में पढ़ा था, because then you will finish off everything of neoplasia with ALK. When they say ALK gene, and if you have to think of lung cancer, it's in front of you, it is adenocarcinoma lung. And if you have to think of a lymphoma, that is also in front of you, it is anaplastic lymphoma. Before we almost come towards the end, can you tell me कौन सा translocation था for anaplastic lymphoma? I told you FMG में PYQ है. What is that translocation? It is translocation 2-5 that we had studied. Perfect answers. Great guys, great going. एक और ऐसा बता दो. I think 3 more questions and done for the day. NK cells, 3 one-liners that you answer, less than 3 minutes, our class will be done. NK cells में CD16 and 56 are markers. Tell me the third marker which they asked you in NEET and INI, which was at that time a very tough question. Now you know 16, 56 and 94. Perfect. That is all that you had to know about the markers of NK cells and the CD markers. Further, if I give you the same question and I say, you want to know the markers of NK cells, that is CD16, 56 and 94, which technique or machine will you use? What is the CD marker ke liye machine known as? Flow cytometry machine we will use. Let's go on to the second last one-liner. Cambium layer is histologically seen in, या तो ऐसे लिखेंगे या फिर they will say a picture is there. Can you see all the cells are on the top? इतना तो basic you can just by looking at on observing you can see. जो भी cells हैं ma'am, they are somewhere on the top and this area is looking very very hypocellular. कुछ है ही नहीं, it's looking very खाली खाली. Now this layer that they are talking about out here, this is the cambium layer that is seen with the skeletal muscle tumor. Skeletal muscle मतलब myosarcoma. Skeletal muscle basically means it is a rhabdomyosarcoma. Smooth muscle hota to leiomyosarcoma, but this is skeletal muscle. They will ask you future questions. Any sarcoma mentioned over here, कोई भी दुनिया का sarcoma हो, on immunohistochemistry, sarcomas are positive for vimentin. So that will to tell me that yeah, some sarcoma is there. But what will tell me skeletal muscle sarcoma, that would be the question. If they say desmin and myo D1 positive, that is when you will start thinking, अच्छा ये skeletal muscle का है, it is rhabdomyosarcoma. And if they would have said smooth muscle actin positive, then you will think of smooth muscle का cancer, you will think of leiomyosarcoma. So if they say there is, forget this question, they say there is a thigh mass. Anyway, thigh में skeletal muscle होता है. So thigh mass है with vimentin positivity, desmin and myo D1 positive, you will think of rhabdomyosarcoma. If they say there is a uterine mass, uterus में smooth muscle होता है, even by basic anatomy I can guess that. Uterus में smooth muscle होता है, तो uterus में vimentin and smooth muscle actin is positive, you will start thinking more in favor of leiomyosarcoma. So focus on these markers, but don't forget your basic anatomy. Which brings me to the last question. Which is the most suitable biopsy specimen for a thyroid biopsy? I would never have made this question, but this is how it was written. But what we gathered is, after reading the options, examiner instead of biopsy actually wanted to ask you for FNAC. Sometimes FNAC is written as FNAB, means biopsy, but again, that should not have been the ideal situation, but that is how it was written in one of the previous year NEET PGs, and hence I got this as the last question. कई बार ऐसा होगा that I have not done the biopsy criteria for thyroid, but when I read all this, I was like, this is to the FNAC criteria for thyroid, so I just adjust. This is known as adjusting while giving the exam. एग्जाम के टाइम पे बैठ के एग्जामिनर की गलती नहीं निकालनी, हमें बाद में आके निकालनी है. वहाँ पर adjust to the situation, flow like water, and whatever the examiner is making a vessel, take the shape of that vessel and just adjust, just flow like the examiner wants you to, and attempt. And tell me what is the adequacy criteria for FNAC. How many cell clusters? I think if all of you have answered D, which I can see, some of you answered B, but I think वो थोड़ा 6-10 का confusion हुआ होगा. How many follicular, we always study 6-10, तो क्या होता है 6-10? 6 follicular cell clusters should be there. तो पहले तो how many cell clusters? Minimum 6 cell clusters should be there, and inside every cluster 10 cells. मतलब minimum हर के अंदर you should be seeing at least 10 cells that are present. That is what I call as 6-10. At least 6 clusters. At least now in the exam 6-10 था या 10-6 था. अगर ऐसा कुछ confusion हुआ, because B and D में ही confusion होगा ना. So you will remember that ma'am had made these 6 golas over here. तो 6-10 था. तो 6 clusters should be there, and in every cluster there should be at least 10 cells that are present. Then I'll say the thyroid FNAC is adequate. FNAC तो ठीक है. How much gauge needle do you put in the thyroid? Thyroid is a very critical organ ना. Thyroid के पास there are such major blood vessels, trachea में जा सकता है. So many complications can occur. So you don't want to use that 18 gauge का cannula and put it into a thyroid. You're not doing such things. You are using a very fine needle. The name tells me 25 to 27 gauge का needle use होता है मैम. पतला most needle that you can possibly put and get cells. That is what you are using. That is one question they ask you. Next, they will also ask you that you put this needle, but you did not get 6 clusters or 10 cells in every. You just got total 5 ऐसे dots मिले आपको. 5 cell cluster तो भूल जाओ. Total 5 cells you got. Is that adequate? You will say no, it's not. But in those 5 cells, you are seeing changes of papillary carcinoma thyroid. You are seeing coffee bean nucleus, you are seeing intranuclear inclusions. Do you want to give the report as inadequate FNSE, or do you want to tell the clinician that this is a cancer? So obviously don't hide something like cancer. So this criteria is a generic criteria. Is this followed in case of suspicion of cancer? Not at all. Cancer dikh raha hai to tell the clinician. Although the adequacy criteria is not met, but I see 5 cells and in those 5 cells I see some cancerous changes of, let's say, papillary or जो भी आपको type का cancer दिख रहा है, inform the clinician so that of course everyone can be alert about it. And yes, that's also an end to today's class that we had. So I hope you guys liked it. And if you have any other doubts, of course, you let me know. I will be sharing this PDF in 15 minutes on my Telegram. There will also be a link in the description where you can download it from the app. But in that PDF, I will be adding 3 to 5 questions, which are nothing कुछ ऐसा बहुत out of the box नहीं है, PYQ ही है. Just giving you 5 questions extra for your bonus, for your practice. उनका answer लिखा होगा. Those questions you have seen earlier also, so don't just get into that panic that we didn't discuss it in class. It's just for extra practice that I want you to do. Everything is there from your PYQ bank. As I told all of you, I'll be meeting you tomorrow, but we'll keep tomorrow's session again, not wasting much time. Within 15 to 20 minutes, I just want to tell you what should you be doing, because I received a lot of questions regarding GT score, especially in these last days, and ever since the new pattern came up. Now you have 180 questions, analyzing how many corrects wrong. That is becoming a little bit of a problem for students. So I'll just guide you on that for 15-20 minutes. Quick, short, sweet session we'll have, and that's about it. And I hope you found these 2 PYQ challenge sessions useful. Even if you are doing the Q bank and you don't revise these again, honestly, you will not miss out on much. Once, just go through them whenever you have time. And in the LRRs, which are in the month of August, which I think is the second most common question that I've got in the past 1 month. So yes, in the first week of August, early on in August, they are starting. Earlier, we were thinking of the last 2 weeks of August, just 15 days before your exam. On your request, we pushed it to the beginning of August. So that will be taken care of. Tentatively, PATH is on 4th. I mean, I'm just killing your FOMO because you guys are too anxious about it, but I will update you on the final dates within 2 or 3 days. But yeah, tentatively it's on 4th of August, okay, and micro will be after that. How is general and systemic divided in NEET? Nowadays, systemic is coming more because they are more into, questions of integration, medicine, gynae, surgery integrated with PATH. That is why students feel that, systemic pathology has gone up and general has taken a back seat. Whereas in INI-CET, general path is given more importance to. But yeah, the last 3-year trend of NEET is that systemic has taken up more. LRR will be theory based. For everyone who has this next question, MCQs, अगर आपको new pattern, old pattern, कुछ भी practice करना है, I'm having alternate day quizzes on my Telegram group, and that is for full month. I have kept it only because I cannot make you solve 200-300 questions in 2-3 hours of LRR with theory revision. वो possible ही नहीं है. Then we'll end up creating a big mess out of it. ना theory revise होगा, ना MCQs होंगे. That is why for MCQ I have conducted or kept 1 full month of Path Micro Telegram quizzes, so that MCQ practice is happening almost on a daily basis. And then LRR becomes like that last 3 hour sure shot one, stop revision where I don't have to go for 250 pages of my notes. I have everything in less than 50 slides. That is the purpose of LRR. So I am not going to go too much into questions in LRR. For that I've kept the quizzes, and LRR I'll keep for all your tables, images, everything that you should be looking at once before you enter the exam hall. GT के बात कल कर ले. I know I'm ignoring those options right now because I don't want this. I want to guide you properly is the point. I don't want to just skip through it for the heck of answering right now. I want that tomorrow, just listen to me for first 10 minutes. Whether I'll tell you range wise, आपके 100 ठीक आ रहे हैं, 110, 20 आ रहे हैं. Whichever phase you are in, I'll guide you accordingly, and I think that will be a more structured way of discussing that. आज GT का बस it's just a matter of less than 24 hours. I think we will have a better discussion tomorrow, and that will help you probably in the way forward. Very afraid of seeing competition. So Dr. Abina, वो तो life में हर जगह रहेगा. I mean, let's get away from NEET PG. You will, after NEET PG, you will go into residency. You will be competing with your fellow colleagues. Then after that you'll have a competition for entering into senior residency, then to a job or your clinic or anywhere, or SS जो भी करना चाहोगे. So the competition will always remain. You will never be the sole lone warrior standing at any place in life. So either you can just ignore all of that and focus on yourself. That's why they say you have to compete only with yourself. So your competition is your last GT score. आपको आपके फ्रेंड के GT स्कोर से अपना GT स्कोर नहीं मैच करना है, आपको अपने प्रीवियस स्कोर से 10% का इंक्रीमेंट लेके आना है. एंड दैट इज एप्लीकेबल टू एवरी फेज ऑफ लाइफ. I am competing till date. I have been competing since I was born. Same goes for you. You have been competing in school also, then in college, now in NEET PG, and you will continue to do that for a lifetime. So either you can take the stress, and that will only take a toll on your mental health. So better क्या है कि let everyone, I wish everyone does the best, but then I will try to do the best test. That's a better approach rather than focusing कि दूसरे क्या कर रहे हैं, competition ज़्यादा है, rank नहीं आएगा. Those are things which work so much on luck. That is not where knowledge comes. And now just imagine when the questions have come down to 180, every one question, right or wrong, is going to skip ranks in thousands. Do you have a control on that? I mean, as a human being, आप silly mistakes तो करोगे ना. You will also do it, I will also do it. So will rank 1 of NEET PG do it. सिली मिस्टेक सबसे होगा, उससे रैंक में 1000 का जंप आएगा, बट दैट राइट नाउ आई डोंट हैव अ कंट्रोल ओवर, क्योंकि वो एक ह्यूमन एरर है जो सब करेंगे वहाँ पर. Right now I just have a control, give my best in the preparation phase, give my best on the day of the exam, and after that just vanish till the result comes. That is what you are supposed to be doing ideally, without thinking कि कौन कितना पढ़ रहा है, कैसे पढ़ रहा है, क्या competition होगा, what will be the cut off. All of those are later stage things. अभी वो सब सोचोगे तो you will not focus on what needs to be done right now. Okay. वीडियो बेस्ड LRR अगेन 180 में से कितने एक्सपेक्ट कर रहे हो वीडियो? फॉरगेट पैथ माइक्रो, 180 टोटल 19 सब्जेक्ट MCQs में से हाउ मेनी वीडियो बेस्ड? नो वन नोज, इट्स जस्ट एन एस्टिमेटेड नंबर. 20 आ जाएंगे, बहुत ही ज़्यादा टफ पेपर हो गया, 30 आ जाएंगे. Do you want for those 30 questions upper limit of video based, we should change the 150 remaining questions and entire LRR should become video based? No. But if you want to ask me कि मैम main videos include कर देना, वो ठीक है. बट पूरा LRR का कॉन्सेप्ट या पूरा आप अपना रिविजन ही अगर वीडियो बेस्ड चेंज कर रहे हो तो देन यू आर मिसिंग आउट ऑन आप 30 क्वेश्चंस. मे बी यू विल गेट 30 on 30 इन द वीडियो बेस्ड क्वेश्चंस विच आर सो अनएक्सपेक्टेड, बट द रेस्ट ऑफ 150 क्वेश्चंस क्या प्लान है फिर? तो डोंट जस्ट गेट ऑब्सेस्ड. हाँ आएंगे वीडियो बेस्ड क्वेश्चंस, एक्सपेक्टेड है, इट इज एंटिसिपेटेड. पूरा पेपर वीडियो बेस्ड नहीं आने वाला. सो डोंट स्विच योर एंटायर प्रेपरेशन टू वीडियो बेस्ड. Stop running after those AI generated videos that are circulating on every Instagram channel right now. सब कुछ AI integrated नहीं आएगा. Maybe some person who's, maybe if I had to set up the exam paper, I would give a video from my lab or from a patient that I saw. तो मुझे नहीं आता AI generate video करना. तो then you are preparing from random sources which is not solving anything. Yes, go through them, scan through them, answer them, but don't just get obsessed with video questions as of now. NEET PG LRR कब आएगा? A question which I think till the time I keep the live on, that question will keep on coming. It's starting in the first week of August. सब भूल रहा है डॉक्टर दिव्या, नेवर माइंड. यू आर अ ह्यूमन बीइंग, तो ह्यूमन ब्रेन है ना. यू आर नॉट मेड अप ऑफ एनी सॉफ्टवेयर, कंप्यूटर, AI तो नहीं है. तो भूलोगे तो यू रीड इट अगेन and then you will forget it again. Let me tell you beforehand, then you will read it again. Today, I remember all this because I'm saying this on a daily basis since years, and this is one subject that I'm studying, practicing every day. तो कुछ चीज़ें फिर आपके mind में embed हो जाती हैं. You tell me that ma'am for 1 year you don't practice pathology, you don't study pathology. After 1 year, do you think I will also remember all of this? No, remotely, maybe 50%, because I'm also a human brain. So Dr. Divya, don't be harsh on yourself. अभी आपको 19 सब्जेक्ट्स पढ़ने हैं, राइट? सो यू कैन नॉट रिमेंबर एवरीथिंग, यू कैन नॉट बी अ मास्टर ऑफ एनी वन सब्जेक्ट, यू डोंट इवन हैव टू डू अ PhD इन एनी सब्जेक्ट, यू जस्ट हैव टू नो 75 to 80% ऑफ एवरी सब्जेक्ट. 100% आपको किसी भी सब्जेक्ट में जानना भी नहीं है. दैट इज नॉट इवन द एक्सपेक्टेशन फ्रॉम यू. आपको 75% जानना है, दैट्स इट. एंड आई थिंक यू हैव डन दैट मच, वो आपको आता है. और खिचड़ी बन रही है, दैट इज ऑल्सो फाइन. पढ़ोगे तो खिचड़ी बनेगी, नहीं पढ़ोगे तो फिर यू विल बी लाइक अ ब्लैंक स्लेट. तो दैट जस्ट टेल्स मी दैट यू आर स्टडिंग, तभी कन्फ्यूजन हो रहा है. इफ़ यू आर रीडिंग लैंग हैंड्स एंड लैंगर हैंड्स, पता होते हुए भी गलत पढ़ रहे हो, दिस मीन्स पता है तो ही तो गलत पढ़ रहे हो ना. इफ समवन डज नॉट नो समथिंग ओनली, तो फिर द कन्फ्यूजन विल नॉट अराइज. सो गेटिंग कन्फ्यूज्ड, डूइंग सिली मिस्टेक्स, दीज आर आई मीन right now you're not won't agree to me, but post exam you will come back and definitely agree with me that ma'am these were good signs. पढ़ा था तो confusion हुआ, पढ़ा ही नहीं है तो फिर then you will be clueless, तो confusion होगा ही नहीं. So let the khichdi happen, it's okay. Dr. Saini, for HIMAT, you will first, you've read your notes. HIMAT के questions solve करके ही approach बनता है. HIMAT is something which no one can teach you in the form of tables or images. You study that rapid revision notes भी पढ़ लो अगर इस time पे. After that you sit down with the Q bank. 3 chapters. उसमें से भी confusing वाले 2 हैं, RBC and WBC. Platelet is a very small chapter, right? So you can ignore that for the time being. RBC, WBC में मिला के कितने questions होंगे? Let's say 50-50 also if you're doing 100 questions. 100 questions if you will solve, I'm not asking you how many you got right, but when you solve 100 questions of a topic, you will automatically understand the approach to those questions. गिनती के भाई 3-4 questions है. Either they will ask you clinical based questions with a biopsy report, tell me ALL है, AML है, or they will ask you those CD markers, or they will ask you investigation of choice. तो अगर ऐसे आप 100 questions solve करोगे तो automatically that approach will build. So just dedicate half a day to those 100 questions, and if you think you have a mental block with regard to HIMAT, get that mental block out. Thank you so much guys. LRR ठीक रहेगा? LRR नहीं, LRR I mean only LRR ठीक रहेगा? वो नहीं रहेगा. इतना तो I mean I want to give you all the confidence, but I cannot give you false confidence ना. I can't say कि सिर्फ LRR पढ़ के चले जाओ. उससे तो कोई भी एग्जाम नहीं हो रहा आज की डेट में. No single exam. Even FMG, which is considered as a so-called screening exam, वो भी नहीं हो पाता सिर्फ LRR से. So LRR is like, I always consider it as mental satisfaction, क्योंकि आपको last के 20 days में पता ही नहीं ना, how should I finish 200 pages of one subject and then multiply by 19 subjects? It's insane. It's not doable. That is when LRR comes to your rescue कि मत पढ़ो 200 pages, उसका short version 50 pages, 30 pages ऐसे पढ़ लो. Does that complete 100% of the syllabus? No. Will that have a 100%? आजकल वो strike rate calculate होता है ना, तो उसका 100% strike rate भी नहीं होगा. Maybe shorter subjects का हो जाएगा, जहाँ पे 3-4 question आते हैं उनका हो जाएगा. But medium to long questions and clinical integration having a 100% strike rate is very unlikely. तो LRR सिर्फ पढ़े हो नहीं. But हाँ, if you've been consistent in the last even 6 months and you've done, let's say, rapid revision videos or any other source, and now in the last 20 days you shift to LRR, so that 20 days में 19 subjects मुझे 2 बार revise करना है. मैम मैंने बार-बार LRR करा, साथ में book marked questions and PYQs करे. That's going to be the most excellent way of approaching this exam. But अगर one fine day you wake up and you say LRR alone will suffice and will help me crack this exam, that I mean I want to stand with you in every phase of life, but this is where I cannot stand with you because I can't give you false hope out here. तो सिर्फ LRR नहीं, but हाँ पहले पढ़ा है LRR, उसको supplement कर रहे हो, definitely yes. How many hours to study? 40 days or less left. 10 hours तो try करो. I know I'll sound a little toxic as I say it. On a regular day, I would have said 6 to 8 hours. My basic concept is कि आप 6 to 8 hours की sleep ले लो. That is one thing. That thing I have settled for you. ठीक है. Then I would also want to say अपना 2 hours of you keep for walking outside. If you like exercising, you do that. Do something which is non-academic. अब इसके बाद rest of the entire day is left to you. 1 to 2 hours more you take out of this, you want to do obviously as a human being, खाना पीना, relax, etc. वो भी हो गया. So now if I take these 12 hours out of your life, I have still left you with 12. After making you sleep for 8 hours, after making you have physical activity for 2 hours, after making you eat, talk to your family, everything for 2 hours, I have still left you with 12 hours. अब उस 12 hours में से I am saying आप 10 hours पढ़ाई कर लो. Because 10 बैठोगे तो 9 या 8 का आउटपुट आएगा. You also know this. So I'm still giving you that buffer in between कि midday nap भी लेना है तो वो भी ले सकते हो. You want to watch some YouTube lecture, that also you can do. So now when you listen to it this way, it is doable कि हाँ पढ़ तो सकते हैं 10 घंटे, but नहीं पढ़ रहे हैं तो where is the lag that I am having? Now you need to calculate कि with sleep, with physical activity, with खाना पीना and with 2 hours of buffer, if then also I'm not studying for 10 hours a day, तो there is a major concern in my timetable. ये fix कर लो बस. ठीक है? Done. I'll meet you tomorrow. GT answers I am ignoring. GT answers I will take tomorrow. And any doubts you have, only 20 minutes का session करेंगे. We will join quickly at 6 and we will not waste any time. 6:20 तक keep your doubts ready. Listen to me for 5 minutes about the strategy. Ask me your doubts after that, and by 6:20 we'll wrap up. Okay? Thank you. कोई और academic doubt है, path related, micro related, put it in the comments. Previous doubts that you had put up in the previous video, I have already answered. You can, go to the comments and find out if you had put up something there. If you have something with regard to this session, you write it over here. Otherwise, you can contact me on Telegram and give me 5 minutes. I will send the PDF to you in 5 minutes or so. Thank you so much, guys.